So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which we call the Gallagher fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture, a 17-year-old gentleman, and the forearm Gallagher fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this Gallagher fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for Gallagher fracture, and this is not reported in any literature. For such a severely displaced fracture, the tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of Gallagher fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail and technique was minimally invasive. And whereas in this left radius, the Gallagher fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for Gallagher fracture. So, but I left it and wait for it. This is the 8-month follow-up. Still there was better union than 6 months. But this was not hypertrophic, and this is 11 months, you can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors have been formed. It was not hypertrophic non-union, it was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present. And the tense nailing is provides sufficient stability for secondary union even in length critical fractures, because the narrow canal and the length should be maintained to, and DR UJ should be reduced properly. We followed the throughout the 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for Gallagher fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirmed that interlocking nailing of femur and tens yields higher union rates and excellent functional outcomes. This approach should be considered for Galeji fracture in adult after further studies, because I think this is the first case in severe Galeji fracture. I did tens. So this case was published in International Journal of Orthopedic Sciences. To provide stable fixation and earlier mobilization and reduces the risk of non-union and malunion. Hence, is less invasive, resulting in smaller incision. Conducted a study between March 2020 to March 2025 on 25 cases of the displaced fracture of the clavicle. The age of the patient was 16 to 48 years, and no comorbidity was found in our study group. All patients treated with titanium elastic nailing. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, that type of communicated fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. The 15B1 is a spiral and oblique, whereas 15B2 is the transverse and short on the fracture. So the patient lies supine with affected limb elevated and hanging outside the table, so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision, there is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious, because the heart and the lungs are like vital structures, are waiting for your instruments to escape. So this is the very crucial step. And then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nailing was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb at the 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 weeks. The 6-month final follow-up was 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 16% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail bite count, superficial infection, and malunion each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases. The radiological as well as clinical picture, as you can see, this is 15B1 fracture, treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the 1ST surgery, no instrument was used to reduce the fracture, only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did. The 15B1 fracture has been treated by titanium elastic nailing. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site, there is secondary callus formation. 1 bump is due to secondary callus formation, and other at the entry site, you can see that there is hardware prominence. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case, 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with the plate and screw. But we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. And the limitation of this surgery and number of cases included in this study was small, and the short period of follow-up, and this is the retrospective duration and the prospective. And the short period of follow-up, and this is the retrospective duration and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS nailing is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here. ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापेटलर नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैलिएबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। अब नेल को फाइनली लोअर एंड ऑफ द मेडुलरी कैनाल डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है आरसीटी नेल इंट्रोड्यूसर कंपोजिशनर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सी आर्म के मदद से गोल करने के बाद होल को गोल करने के बाद इस तरह से सी आर्म को एडजस्ट किया जाता है कि होल गोल दिखे और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है। अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। फाइनली दोनों स्क्रू को उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को, और अब लोअर फ्रैगमेंट के एंट्रोपोस्टेरियर जो होल है उसको गोल किया गया है। इस तरह से सी आर को एडजस्ट किया जाता है कि वो गोल दिखे और एंट्रोपोस्टेरियर स्क्रू को डाल दिया गया है, जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है। इस तरह से सी आर को एडजस्ट किया गया है और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैगमेंट फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये आरसीटी नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला।
हेलो फ्रेंड्स, टुडे आई एम गोइंग टू गिव ए डेमो of interlocking nailing in fracture shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the shaft femur. So this time the patient had come to me for the lower third fracture of the shaft femur or other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeter diameter, and then after blood dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the piriform fossa in AP view. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am having the bone out inside the intramedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the AP view. It has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3, at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make an space in the leg. And my assistant is keeping the fracture in reduced position throughout the nailing process with the help of the F tool. During reaming process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. And after performing in the CR in both views, we did reaming up to the lower end of the femur, and finally we reamed this fracture. You can see in the CR picture, it is reduced, although they are slightly distracted, but in reduced position. Can be prevented. And finally, I have introduced the appropriate size nail up to the upper bone of the back latitude. Good position, the fracture is reduced in both view, in the oblique view and lefty view and lateral view. And when near cortex is perforated with the help of 2.5 millimeter K wire and the distant cortex is drilled with 3.2 millimeter drill bit, and finally we select a proper size 5 millimeter screw for proximal locking, and in my freehand technique I will make the hole circular after adjusting the CR in lateral position, and I am tightening the screw after drilling with the wound, after forceful wash of the wound, so that all the now I am closing the wound after forceful wash of the wound. Now the wound has been closed. Hello friends, I am Dr. R.C. Thakur, iliac spine down to the table, and another line from the tip of the greater trochanter towards this first line, and the point of bisection of these two lines is the point of incision for this surgery. So I am making an incision at these bisecting points where the two lines bisect. So I am giving incision about 2 centimeters, as you can see in the picture. So I am feeling the correct point of entry. I am confirming, I am introducing a bone out at the correct point selected, and then I am confirming this whether this bone out is entering at correct selected point or not in C-arm picture. So I am introducing the owl in correct position after confirming the entry point in C-arm picture, both in AP and lateral view. So this is the AP view. It is entering in proper selected position, and this is inside the intramedullary canal in correct position, going medially in AP view, and this is hammered if it is in place inside the intramedullary canal in proper position, confirming in both AP and lateral view. And then I will pull this bone out for 2 centimeters to introduce the guide wire. The depression or groove present in the lateral side will guide this guide wire inside the hole, and the guide wire is entering inside the intramedullary canal along the depression or groove present laterally in the owl. So it is inside the intramedullary canal, well placed in AP view. And now I will remove the owl. So I have removed the owl, and I'm doing reading of the upper part of the nail is about 15 millimeter diameter. So I am reaming this, and my assistant is pushing the reamer sleeve medially so that it goes in correct position. So it has been reamed with 15 millimeter reamer, and now I am introducing the nail of selected size
and I will hammer the reamer with the help of supine. Drive. I am hammering the nail inside the intermedullary canal so that the hole present in the nail comes in the central position of the neck of the femur in AP view and of the neck of the femur. And I am confirming it whether it has gone in central position in both AP and lateral view. You can see in the picture, it is in very good place. It is central in AP view and central in lateral view also. So I am doing rimming. Some surgeons do rimming up to the lateral cortex only, but I do rimming up to the size of the nail. Is introduced in proper position, both AP and lateral view, and then my assistant is attaching the arm for distal locking guide wire in the lateral cortex. And after confirming it in CR picture, the final tightening is being done now. The lateral view, and this is the AP view post-operative. So thank you everybody. My anesthetist, my assistant, my supporting staff. I think this is the well-executed team for a old osteoporotic patient, for unstable. The number one myth is interlocking nailing of humerus will severely impair the shoulder function due to rotator cuff damage. The reality is, with proper technique and entry point, the rotator cuff damage can be minimized and shoulder function can be preserved. So the myth number two is there is always chance of radial nerve injury as it is a complication for the interlocking nailing of humerus. And it is not a complication for the open reduction and internal fixation for plating. So it is, yes, it is, there is risk of radial nerve injury when the fracture is at the spinal root. There is chance of the radial nerve injury, but in the rest of the part, if the fracture is in the rest of the part of the humerus, there is minimum chance of the radial nerve injury when the instruments like the guide wire, reamer, and the nail is introduced after proper reduction of the fracture in the distal fragment. Both AP and lateral view, the fracture is reduced properly. Only then these instruments are introduced inside the distal fragment. And don't allow your instrument to wander inside the soft tissue. So these are the two myths which is associated with interlocking nailing of humerus, and other two controversies whether which position of the patient should be used for the interlocking nailing of humerus. There are three positions. Number one, supine position. When it is used, it is comfortable for the anesthesia point of view as well as the surgeons. But the distal locking, which is done by freehand technique, is slightly difficult and tricky because the anterior surface of the distal part of the humerus is triangular. So finding the entry point for the distal locking is slightly difficult because slipping of the drill bit or KY. So it should be at angle, it should be introduced at angle, and then it should be kept in a straight line. So this is the disadvantage of supine position, and in lateral position as well as the prone position, the distal locking is done from the posterior surface, which is flat. So the entry hole, finding the entry point for the distal locking is easy because the surface is the flat, but it is uncomfortable position for anesthesia point of view, and the surgeons, it depends on the surgeon's choice. So I do use supine position for all my interlocking nailing. Number 3 controversy is because it is non-weight bearing bone, so one screw distal and one screw proximal is sufficient. But I use 2 screw distal and 2 screw proximal because the 2 is always better than 1, always stronger than 1. If it is just like the 2 kidney present in human body, if one fails, other start working. So, and 2 engines in the aeroplane, one engine fails, the other start working automatically. So, if one screw is not working, then the other screw will do its work. So, the fixation is better by 2 screw proximal and 2 screw distal. So, friends, these are the advantages of locking nailing over the plating of the humerus, and these are the myths, and these are the controversies whether 2 screws should be put proximal as well as the distal, what position should be used in this talk, and let us get tuned for the next video and subscribe my channel